We take a look at the American healthcare system, such as it is, in Chapter 12 of the Carter text. This is an area that is ripe for exploration in terms of policy proposals and advocacy. And I suspect that over the next 10 to 20 years, there's going to be many different changes and alterations in our system. Whether it's for the better or the worse is going to depend upon a number of factors, as I think is fairly evident at this time. About 13% of Americans, as of the writing of this text in 2014, remained uninsured. Um, a website, the census website, as mentioned below, indicated that by 2017 that figure had dropped to 8.8%, which is pretty remarkable when you consider, well, actually, that would have been the first year of the Trump administration, which has really been pushing against the Affordable Care Act and trying to limit its effectiveness, as we'll touch on later in this discussion. But at least through the final years of the Obama administration, efforts were made to continue to increase enrollment so that um, our figure was around 9% of Americans uninsured by that point, still representing over 28 million people without insurance, without health care insurance. In 2017, private health insurance coverage continued to be more prevalent than government coverage. At Private health insurance covering about two-thirds of the population, and another third, actually a little more than a third, had government coverage. Now, there of the subtypes of health insurance coverage, here's a breakdown that is, when you look at different websites and you compare different years and things like this, these figures go up and down. But roughly, this is the case. That about, well, a little more than half of the population has some type of insurance that is employer based. I think somewhere I read where it said almost half, so that may be changing some, but around half of our population has employer based insurance. About a fifth of them have Medicaid coverage, and roughly again a fifth have Medicare coverage. Direct purchase coverage, which would really include those individuals who are shopping through the Affordable Care Act in the health insurance marketplaces, if you want to call them that, about 16%, and another almost 5% have military coverage for their health insurance. This, of course, is as everything in our nation. There's a difference in terms of your health coverage as far as your race is concerned, so that non-Hispanic whites have the lowest uninsured rate, about a little over 6%. Blacks have about a 10 or 11% uninsured rate, Asians about a 7% uninsured rate, but Hispanics had the highest uninsured rate, which is about 16%. And my guess is that includes undocumented immigrants. Between 2016 and 2017, the percentage of people without health insurance coverage decreased in 3 states, but increased in 14 states. So this is not progress that's going on universally across the nation by any stretch of the imagination. Um, the Axios website, which is admittedly a liberal-leaning website, it's a kind of a news gathering website, refers to the healthcare system um, in March of 2019 as a fragmented healthcare system. It has one system for workers and another for the unemployed or self-employed. Then have Medicare for seniors, Medicaid for low-income families, another system for the military, another for Native Americans through the BIA, the Indian Health Services, and all this patchwork, as other parts of our social service system have been described. This patchwork of healthcare systems contributes to the wasteful spending that is a part of the expense in our healthcare system in America because of all these administrative costs, and this fragmentation is really very unique around the world. In other countries, employers contribute but not be responsible for providing the insurance, according to a health economist at the London School of Economics. She said that it's not unique to have a public and private system existing side by side, but to have so many public and private programs coexisting, she says, I can't think of another country that has that. Almost nowhere in this process, in this convoluted process, does the United States do much to control health prices, which is another issue. And it's another big difference with similar countries, and is a big reason for the system being as expensive as it is. We don't use the power of government to break up monopolies or ensure that the market for such things as hospital care, uh, prescription drugs, all those kinds of things are actually competitive at all. If you're uninsured in America, you're more likely to not receive the medical care you need. You're more likely to need hospitalization for acute conditions. You're more likely to rely on emergency room services excessively because other people won't see you. You're turned away for your inability to pay in non-emergent situations and are more likely to um, more likely to put off seeking care as a result of that. Less likely to fill a prescription or to get treatment because of the expense of those items. More likely to be contacted by collection agencies, just further adding salt to the wound. If if uh, if you're hospitalized for a heart attack, you're 25% more likely to die while you're in the hospital. And if you're in the hospital for a traumatic injury, you're more than twice as likely to die. You're going to lose more wealth than the people who are insured with similar diagnoses because you're spending more money on it, and you'll pay thousands more in medical expending for serious medical conditions than the uninsured will. And if you're children, you're more likely to have developmental delays than insured children are as well. So you can see that the impact of not having health insurance is really very widespread and contributes heavily to the poor health of the uninsured in our nation. The cost of medical care for the uninsured was nearly $85 billion in 2013 alone. We look at a few of the programs in our public health insurance system in the United States, not the private but the public system. Medicare is, after Social Security, the largest social insurance program in the U.S. and is the largest single payer of health care at close to 20% of all healthcare spending. Now, Medicare is broken up into four different parts as of this as of this taping. Part A is the one that's compulsory for most everybody over 65. This is a hospital insurance that covers you if you have inpatient services, and is free to those over 65 eligible for Social Security benefits and railroad retirement. It's funded through the Medicare payroll tax, which all of us um, well, yeah, actually, all of us pay, even if you're not in the Social Security system, which some people in the state of Alaska, for instance, are not. You still pay a Medicare tax of it's like I think 1.65% or something like that. Part B, which is the supplemental insurance, medical insurance program, really covers outpatient services and is well, apparently it's voluntary. But for instance, for myself as a retiree of the state of Alaska, my in order to have continue with my insurer being a secondary insurance plan, I had to sign on to Part B. So it's only voluntary to a certain extent. If you have other insurance, you're likely required to get Part B, and this is funded by in part at least funded by a monthly premium that Medicare eligible individuals pay every month, whether from their Social Security check. If they don't have Social Security, I guess they get billed for it. Um, and it covers, again, as I said, outpatient care and services, and usually will pay 80%. And so the individual is left to pay the other 20%. If you don't have a secondary insurance, then you're paying that much out of pocket. Um, so this is financed through the monthly premium that beneficiaries pay, and then the rest of it is paid for out of general tax revenues. Part C, which is the Medicare Advantage program, is something that I think most Medicare recipients don't participate in or aren't aware of, but it provides private insurers enter into this pool here and offer alternatives that I guess are managed or monitored closely by the public Medicare system, and they provide some alternatives to parts A and B. And for some individuals, you pay additional premiums for Part C for Medicare Advantage, but for some individuals, it is more beneficial to have Part C than Parts A and B, I guess, because like Part C in some cases will cover that other 20% and those kinds of things. For some it's cheaper, others it's not. It depends a little bit upon your medical picture, I suppose, and what kind of services you're likely to use or you do use. Part D, which came around in the Bush administration in 2005 through the Medicare Drug Improvement and Modernization Act, the MMA, provides prescription coverage for Medicare recipients. Private insurers offer Medigap insurance, which is different from Medicare Advantage, and it sometimes can be easily confused. When I first started getting the literature as I was turning Medicare eligible, it was confusing to figure out what the difference was between Medicare Advantage and Medigap. But Medigap are private insurance programs that really are you purchase, I think, outside the Medicare system altogether that will cover the 20% that Medicare Part B doesn't cover, generally speaking, and for some things Part A doesn't pay 100% as well. So, but again, that's for those. That's sort of the secondary insurance for those that don't go into retirement with a secondary insurance program lining up. Medicaid, oftentimes confused with Medicare. Both were established in 1965 during the Lyndon Johnson administration. And Medicaid provides medical care for those without private insurance and who don't have the money um, um, to purchase their own insurance. Now, um, before the establishment of Medicaid and Medicare, really the charitable organizations of state and local governments were left to care for them. And with some amendments in the Social Security Act in 1950 and later on in the 1950s, I think the states were encouraged to provide medical care for indigent persons. They were allowed to do that under the Social Security Act. In the 1950s, but several states still declined to participate in that. So the elderly poor, for instance, were often left without medical coverage if they were not Medicare eligible. Medicaid itself is a means-tested program and is the largest public assistance program in the nation. It's a combined federal-state program so that the states determine eligibility one by one, but there are broad federal boundaries within which that eligibility must be shaped. So individuals may be eligible for Medicaid in one state or have certain coverage for things, but they move to another state, and all of that changes again. And so that's something that is different from Medicare, which is consistent across the nation, and it's strictly a federal program because the states administer Medicaid. They have more control over what's paid for and what isn't. And under the mandatory guidelines for Medicaid, among those that are served are low-income families with children. Oftentimes, these would be your TANF recipients, SSI recipients, infants born to Medicaid-eligible women, children and pregnant women with family income below 133% of the federal poverty level, 4E eligible recipients of adoption assistance and foster care. I think it was in last week's, I believe it was last week's learning unit. I opened with a little description of my own experience applying for state Medicaid in Alaska for my middle child. It was this program actually, this is the federal program here, the federal 4E. This is the program he was not entitled to because of some peculiarities in his family situation and in how his case was or was not documented, and so I had to apply for state Medicaid as opposed to the federal program. In any event, the federal government funds Medicaid coverage for eligible recipients of adoption and also for foster care children. Now, these are generally children. This isn't if you go about a private adoption, for instance, with through an attorney or something like this, they would not necessarily be eligible. They wouldn't be eligible for Medicaid coverage. But these are kids that are 4E eligible, Title 4E of the Social Security Act. Generally, kids that have been in foster care before and who came from families that might have been eligible for TANF. Some Medicare recipients and some protected groups are also eligible for Medicaid, and then other categorically needy groups as determined by the state, where the states can extend benefits above the eligibility level and also to the near poor, those that are just over the line. But again, that's a state by state determination. About 66 million people are served by Medicaid or were served by Medicaid in 2014. And actually, I was looking at a website a little bit ago by the Henry Kaiser Family Foundation that said that figure was 80 million. So that was would have been probably well, actually they were 2014 statistics. So again, it depends a lot upon where you go for these statistics, but you get the picture. There's an awful lot of people receiving Medicaid services. And according to our text, 51% were children under 21, 39% were non disabled adults, and 10% were over 65 years of age. Well, first of all, it doesn't say anything about disabled adults, which would be covered under SSI. So I went to the Kaiser Family Foundation website, and they said that 14% of the Medicaid recipients were disabled. Um, that can, and actually, I think the definition they were using was for disabled adults. Their figure for children was actually smaller than this. It was like 43%. But again, and the adults were 34% and the aged were 9%. So, again, you get the idea. About half of the people that are receiving Medicaid are children. I just, these figures, the three that were in the text add up to 100%, but say nothing of disabled adults, and that's why I felt the need to go looking elsewhere. But you can kind of see how it's really pretty distributed. Your non-disabled adults, by the way, a lot of those would be parents who are, parents of children in TANF families and those kinds of things. I wonder if that should say non-disabled and disabled adults. Let's see, if I added the Kaiser family figures together, disabled and non-disabled would be 48%. So, I don't know. While the elderly here are, around 9 or 10%, again, depending upon which table you're looking at, in terms of the people who are receiving benefits or the recipients, they account for about 20% of the total expenditures for the Medicaid program. And this, I think it partly is because it includes payments for long-term nursing home care, which is, as the text points out, is this industry that has just exploded and mushroomed since Medicaid was put in place, and they really do a lot of billing to the Medicaid program for those adults who aren't able to live on their own and don't have private insurance for long-term care. That long-term nursing home care accounted for more than a third of the Medicaid budget in 2012, which, well, I guess because not all people in long-term nursing care are elderly. Again, those figures don't necessarily line up for me, and I'm a little confused with how these figures come out. But just think in terms of generalities. There are gaps in coverage for those very low because of the very low eligibility limits for Medicaid. Those are the near poor we're talking about that many states don't cover. There are and the states refuse a lot of Medicaid options for services, and some have cut back on Medicaid coverage recently. Some elderly and some disabled are not covered for the services they need to have. Um, and poor single persons and childless couples who are not elderly or disabled are also not included in as far as coverage goes. Since implementation, the use of physician services by children has increased. Since implementation of the Medicaid program in 1965. Use of physician services by children has increased. Infant mortality has dropped significantly, and ongoing preventative care that is available through Medicaid for children has reduced the program costs for children under Medicaid quite greatly. In Alaska, the Medicaid recipients will get notices about the EPDST screenings, early periodic diagnosis and screening testing, I think is what that stands for. Generally done, I think you could actually, doctors can do that, can do the EPSDT screenings and fill that out. Otherwise, public health departments, the nurses, public health nurses will do them, and you really it's intended to check kids' health to make sure that they're getting the treatment they need, and if there's any services that aren't being provided that need to be provided. And I think it's actually a requirement every year for kids in Medicaid, and it's a good thing. Here's some information from healthinsurance.org. I just tried to supplement some of this so that we actually talk a little bit about Alaska specifically as well. And healthinsurance.org said that Alaska's eligibility guidelines for Medicaid were pretty generous for children and pregnant women and young adults, that is, those ages 19 and 20, and parents even before Medicaid expansion went into effect in 2015. But non elderly Alaskan adults without children still are not eligible for Medicaid, or were not eligible rather for Medicaid prior to September 1st, 2015. I believe now single adults are eligible for Medicaid coverage. I mean, they can be eligible for Medicaid coverage depending upon income and those kinds of things under the Medicaid expansion implemented in the Walker administration, at least for certain kinds of things. Children from birth to age 18 are eligible if their family income is 203% or less of the federal poverty levels or poverty guidelines. It's called referred to as the FPL here. In other places, it's the FPG. Pregnant women are covered up to 200% of FPG because Medicaid has expanded in Alaska. All adults are now eligible with household incomes up to 138% of poverty level. And if any aged, blind, or disabled persons who qualify for Alaska Public Assistance are also going to qualify for Medicaid, and that should probably say ATAP, not APA. Medicaid expansion, the federal funds paid for it, 100% of it through 2016. And what a lot of the conservative governors who objected to it, including Sean Parnell in Alaska when he was still governor, worried about what it was going to cost the state once the feds stopped being so generous, and whether or not the budget was going to be able to absorb the extra expense. The state began paying the 5% of the cost in 2017 and 6% in 2018, and it's going to increase to 10% and then stay there in 2020 going forward. So the federal government is going to continue to pay by far the largest amount of the cost of Medicaid expansion. And of note here, nearly $1 billion in federal funding has flowed into Alaska's healthcare industry since September 2015 because of Medicaid expansion. If you talk to, I think most physicians and hospitals and medical providers in the state are definitely in favor of Medicaid expansion. I think they see it as a very good thing. It was a big political issue, as it is and remains across the nation. Um, the the Affordable Care Act had originally required states to offer Medicaid expansion, and that was the one thing that I believe it was in 2012 the Supreme Court ruling did not support, so that states were allowed to pull back from Medicaid expansion, and several did. Um, and then continued to sue the federal government for other things about the ACA, which were later thrown out, I believe, by the court. But in any event, Medicaid expansion did not happen in Alaska until September 2015, and then it was over the objections of the conservative legislature. The governor signed it by executive authority. Governor Walker did. Alaska was about a year and a half behind the rest of the nation, those that did expand at least. By August of 2018, enrollment in the expanded Medicaid had grown to over 44,000 persons in Alaska. An additional 44,000 people had Medicaid coverage because of the expansion. And the Census Bureau indicated that the uninsured rate in Alaska dropped from 18.5% in 2013 to 13.7% in 2017. So that's a good thing. This information, by the way, again, comes from healthinsurance.org. For whatever reason, I couldn't get the footer to deploy on this slide. But I did mention here, according to healthinsurance.org, some Republican legislators contended that Governor Walker overstepped his authority when he expanded Medicaid by executive authority. They wanted to ensure that the legislative process is protected, and so they filed an appeal in the Supreme Court. attempting to retroactively block Medicaid expansion, but that case was dismissed in 2016. A few months later, the House of Representatives filed still another appeal, but as the website said, the proverbial horse was already miles from the barn, because Medicaid expansion had taken effect, several months before, and so the House dropped their appeal altogether in June of 2016. Conservatives are dead set against anything associated with the Affordable Care Act. It seems. And not all conservatives, I understand that, by the way, that some conservatives may support parts of it but by and large the opposition to, I think it's clear to see the opposition um, to the kinds of expanded medical care that the ACA has offered, has really clearly been much more conservative than any other group. The State Children's Health Insurance Program is a federal state program, SCHIP, or CHIP as it's called, which is intended to expand health coverage to low income uninsured children under 19 who are ineligible for Medicaid. So this is separate from the Medicaid expansion that we were talking about just now. And in 2015, 8 million children were enrolled in various states around the nation. In order to qualify, the children must fall. These are children now aged 19 and 20, 18 to 21, if you want to call it that, where they can't be on the their Medicaid grant anywhere because they're no longer minors. Uh, so then we're talking about 19 and 20-year-old. 18 and 21 sounds like 3 years, but it's really only 2 years. Well, actually, it should be. I guess through age 18, I think you're still eligible as a child for Medicaid, if I understand correctly. So in any event, these are the kids until 21, that were kind of falling in between the cracks there, and their income must fall below 200% of the federal poverty level. And families with income that are too high to qualify for Medicaid, but didn't make enough money or didn't have a job where private health insurance was offered, then those children could then be insured. Almost half of the states cover children up to 250% of the poverty level. And there are some states that cover legal immigrant children and pregnant women. Again, remember now, illegal immigrants, undocumented immigrants, not covered here. Okay. Our SCHIP program in Alaska is called Denali Kid Care, I believe, or at least part of the SCHIP program is, and it provides health insurance coverage for children and teens through age. Well, okay, I take that back. Covers health insurance coverage for children and teens through age 18. So these are the kids that are younger than the SCHIP kids who meet the income guidelines. And here again are the guidelines. Children with no other insurance have to fall under 203% of the federal poverty guidelines. Children who are in families that have other insurance must fall still within 170 cent of federal poverty guidelines. And some pregnant women who fall under 200% of the federal poverty guidelines are also eligible for coverage under Denali Kid Care. Denali Kid Care, in part, I believe, is paid for out of some of the savings that the state claimed because of the welfare reform, at least as I understand it. I think it's safe to say there's a healthcare crisis in our nation, and the cost of providing healthcare is rising faster than the rate of inflation. When you look at the healthcare expenditures, that's all spending, not just public program spending. The highest share goes to hospitals of all the payments. Single and family premiums for employer-sponsored health insurance, these are the private things now, increased by 4% between 2014 and 2015, and I think it's safe to say they continue to go up pretty much every year. Those of you that are paying for health insurance know that. The average family premium for health insurance and such programs was over $17,500. Workers contributing about $5,000 of that through their own premium payments through their paychecks generally. So that means that the employers are paying about over $12,000 on average. Understand though that that's tax deductible for employers, so they can write that amount off, and so employers do find some benefits in being involved in health insurance in that respect. There are a couple caveats about this. That while the premium's only going up 4%, some other things have happened. I've personally aware of the fact that a number of agencies in the community that previously offered family coverage no longer offer family coverage, or if they did, they wouldn't pay for the family coverage. It was up to the individual employee to pay the full premium for family, so that the health insurance benefits being offered through and this is in our field, by the way, the health insurance benefits by some employers would cover the employee, but not the family, not the children, not the spouse, and that it was up to the employee if they wanted that coverage or not. So that's one thing that even as premiums go up, coverage is becoming more restricted. And the other thing that has happened a lot of times is the deductibles, that is the amount that has to be paid by the individual before insurance kicks in, have also increased dramatically. So don't be fooled if you think that a 4% increase in premiums isn't all that great. Well, first of all, it is for some individuals, but there are many other kinds of things that are going on in this picture that is really making healthcare much more expensive for the individual. In addition, when you look at what's going on in the medical field, for instance, doctors are left to order unnecessary testing frequently enough because of fears of malpractice suits and things if they don't test the heck out of every condition that you have. And so there's a lot of extra medical services being provided, a lot of extra expenses being generated, and billings generated as well, thus pushing up the costs of healthcare. We have longer lifespans these days, and that means we have more long-term illnesses and chronic diseases, and so there's necessary interventions and treatments for those diseases, such as type 2 diabetes is one example of that, which of course drive up our medical costs in our nation. Pharmaceutical industries are very well aware of this and are all too happy to raise their own prices, both for name brand and generic drugs as time goes on. And when you look at our system, as fragmented as it is, not only among the several different public programs and then the individual private programs as well, then within the private industry you also have all these different health insurers, all of these having their own administrative hierarchy. There's so much duplication going on that the administrative costs of our healthcare system is excessive, and as mentioned earlier, is one of the reasons why it's so expensive in the United States as compared to other nations with single providers or nationalized systems. It's interesting to note that in the last 30 years of the last century, physician services went up 1,800%. So that means essentially that, whatever in 1970 you might have paid $100 to have done with a doctor, you're paying $1,800 by the end of that century. So physician services have gone up, and much more so than in other advanced nations as well. It's an interesting thing, and another interesting factor, specialists make so much more than general practitioners or primary care physicians do, and the percentage of those two groups has reversed itself, so that years ago it was 30% were specialists and 70% were the general practitioners or primary physicians, and those statistics have reversed themselves now. When I talk about the drug companies, I mean the share of healthcare expenditures for prescription drugs has increased dramatically. 43% of the global sales in prescription drugs is within the U.S. pharmaceutical market. 43% of the whole world. We as one of my exchange students one time remarked, watching television, I think it was cable television, where you have all these different advertisements for drugs for this and drugs for that, and he made some comment about how it is that Americans seem to have a pill for everything, and indeed that does seem to be the case if you pay attention to those things. And our over reliance on drugs is a major factor that contributes to the fact that medical care itself is the third leading cause of death in the United States. Medical care is the third leading cause of death in the United States. Drug companies have increased profits at a rate higher than the Fortune 500 average, often as much as 20%. And again, the price of generics has increased as well. And of note here, the top 10 drug companies make more in profits than the rest of the Fortune 500 companies combined do. One of the things you'll hear about, well, why is it that we have to pay so much for drugs, and in other nations they don't? Well, because you're funding the research, and all the good research is happening here, and we're the ones that are making the advancements. So the fact is, at least according to the information we're given, that drug companies are spending 2.5 times more on advertisement and marketing and administration than they are in research. And, after I think it's 10 years, once a drug's on the market, the patent expires after 10 years. And then that's when generic companies can begin producing that medication, at much lower cost. Generic drugs are so much lower than name brands. But what a lot of the pharmaceutical companies are doing is slightly altering or tweaking the formula such that they can claim there's a new drug now, and it prevents the generic version from actually ever being made. And it also has mentioned the fact, this is something I wasn't aware of, that some of the pharmaceutical companies actually pay the generic producers millions and millions of dollars to not produce generic versions when they might otherwise be able to. The advertising costs over 8 billion, which you see this advertisement on television. You ask your physician about it because it looks like a better thing than you're taking already. The physician worried about malpractice, maybe prescribes that medication, and so of course the sales of those medications increase dramatically, as do the prices. If you spend any time in your doctor's office, and I get allergy shots, and so I have to hang around the doctor's office for a half hour or so after I have the shot, and make sure there's not a reaction to the shot. And it's been interesting watching, that I see reps from drug companies and other medical companies. They're talking to my doctor about different kinds of things while I'm sitting there. It's pretty clear that they're marketing, and they fly doctors out to conferences in Orlando or Rio or wherever, and provide all sorts of incentives. Give doctors a lot of free samples to pass out to patients, and all those kinds of things really increase and spike their sales. One of the things that the Medicare Act of 2005 that extended to prescription drugs, one of the big criticisms of that, we talked about this some weeks back, is that the Medicare system was not given the authority to negotiate drug prices with the pharmaceutical companies like private insurance companies can, and I guess as other nations do. And so that's one reason why the drugs, although Medicare is covering payment of for not all drugs by any means, by the way. There's this donut hole that exists in terms of what seniors pay, where the cheaper drugs are covered and the ultra expensive drugs are covered, but the medium price drugs, they're, for whatever reason, I'm not sure the logic behind this, but that oftentimes seniors are still responsible for making payments for a lot of kind of mid-range kinds of prescription services and things, and that closing that donut hole is one of the things that the Affordable Care Act was attempting to do, I think. The fact that Medicare can't negotiate down the prices of prescription drugs assures, again, ongoing income to the pharmaceutical companies. So they kind of seem to have it coming and going. And likewise, you can get a lot of these drugs cheaper in Canada and Mexico, but we're not allowed to import drugs from those nations, according to the FDA. Medicare does attempt to control costs through a system called the prospective payment system, where they tell hospitals in advance what they'll pay for treatments of all these different classified illnesses. I mean, hundreds and hundreds. I think there were 450 some mentioned in the text. There's probably more than that now. These are called DRGs, or diagnostic related groups. So the hospital knows how much Medicare is going to pay for this patient for this particular condition, and if they're able to offer services and get the patient out of there earlier than the maximum that Medicare will pay for DRGs, hospitals can still claim that difference. They basically make money by kicking patients out early. there are certainly some issues with that, and it's one of the things that happens is that patient dumping, where you've seen that where hospitals put people out before they're really ready to be released, and sometimes without any discharge plan at all. In the 1990s, a concept called managed care came along, which basically said, that insurance companies are going to take control of of services and how much service they're going to be provided. So the physicians and providers have to clear with a lot of times have to clear with insurance company before providing services, and find out whether or not the insurance company is going to cover those things, sometimes pre-authorizing this kind of thing. And certainly in the mental health industry, I know that, as therapists, the insurance company might say for this particular condition you get 10 sessions, and at the end of those 10 sessions you have to provide a progress report, and if you need more you have to justify that and show that. There's a lot of paperwork involved in those things, and the idea is to cut down on services that are being provided. And there's a number of different ways to do that. Also, many of you, if you have insurance, you have what are called preferred providers. Whereas if you go to these doctors or doctors that are in your network, so to speak, um, the insurance will cover more than it would if you go to some physician that's not one of the preferred providers or not in your network, those kinds of things. Health maintenance organizations also was another concept that's become less popular over the years, but HMOs were intended to focus more upon preventative services and those kinds of things. And all of these kinds of things are the insurance companies' attempt to implement managed care. And it really, in many respects, kind of gatekeeps, who you see. And so there's some freedom of choice that is restricted depending upon your insurer, of course, and what program you're in. And the text has a list of, at the time the text was published, at least, of the 25 largest health insurers in the nation. It said that almost two-thirds of Americans that are insured by private companies are insured by one of those in those 25. Interestingly, gun violence is brought up in terms of healthcare, and the authors are presenting it here as a healthcare policy. Although I think you may be aware that the Center for Disease Control and other federal government organizations are prohibited from using federal funds to do any research on the effects of gun violence, as I understand it. So, many individuals in government do not consider gun policy as healthcare policy, but clearly our authors believe we should. And just a few comments about this. A third of the American homes with children have guns, and about something less than 2 million children are in homes with unlocked and loaded guns. In Alaska, for instance, if you have a foster care license and you have weapons, you have to advise the state of that, and you have to, in order to maintain your license, you have to have your guns locked, I think with a safety lock, but also locked away and stored separately from the ammunition, so that you don't have impulsivity on the parts of kids grabbing guns. And I've known of situations with kids running off into the woods and shooting themselves, and other situations where little children just, actually climbed up on top of a bookcase to get a gun that happened to be loaded, and accidentally shot and killed a younger sibling. And these kinds of tragedies happen all the time. Um, Guns and cars are mentioned in the text as the two leading causes of deaths, of non-medical deaths in the United States. If you're an American, you're 20 times more likely to be murdered in a gun-related incident than anybody in another developed nation. And if you're a woman or a child in America, you're 11 times more likely to be murdered by gun-related incidents than those groups in other nations. So if you figure that Americans on average are 20 times more likely, if you're an American male, I don't have that statistic, but you can see it's significantly more than 20% more likely to be murdered by gun-related incidents. Still, though, the NRA is going to point out that gun deaths were at their lowest point in 2010 and in 30 some years. But gun policy is politics now. It's big politics, and it's really prevented progress of in establishing reasonable gun control measures. And probably a few of you listening to it, maybe more than a few of you have are having an internal reaction to the things that I'm about to mention. But like enhanced background checks, which to me seem like common sense. Um, Even Democratic senators from left-leaning state or right-leaning states such as Alaska, Mark Begich had an opportunity to vote for enhanced background checks. I think it was after Sandy Hook, and did not vote for it. And um, you know, it's they're afraid to cross gun owners and the NRA. And now there is some discussion that since the Parkland High School shootings, or Marjorie Stoneman Douglas High shootings, that the NRA is less ascendant than it was at one time. But I suspect that's a temporary condition. Enhanced background checks is closing the gun show loophole, where background checks aren't required at all if you buy a gun in gun shows. Prohibiting large clips, that's another thing that increases certainly the carnage involved in any kind of mass shooting when you have large clips of ammunition in the gun without having to load. An advancement of smart gun technology, where fingerprints are required to get a gun operational, would be something to go a long way to help prevent kids from accidentally shooting somebody. But the trend's been in America such things as the Castle Doctrine, which says that if somebody is in your home, you don't have to try to retreat. You have a right to protect your castle basically and shoot that person. And the stand your ground laws, which have been enacted in several states, um, allow not even in your home, but that if somebody is threatening you, you don't have to you know you don't have to first retreat and then shoot. If that doesn't work, you can just shoot to protect yourself if you perceive a threat. This is that's in the Trayvon Martin shooting. That's how George Zimmerman was excused for that murder. Was the stand your ground law in Florida that was operational at the time. Open carry law is another thing. A lot of states have implemented that, and many states have implemented that on college campuses. And it was proposed a few years ago in Alaska. Apparently, it didn't pass. At least I don't know that it has or not. But you know, I, the old saying that the best defense against a bad guy with a gun is a good guy with a gun. There aren't many episodes where you see good guys with a gun actually stopping a bad guy with a gun, and uh, that's my own observation. But um, I, as somebody who stood at the front of a classroom for many many years, um, the thought of a shooter coming through the door is very disconcerting, no question about it, from behind me probably. But what's even more disconcerting is thinking that there's somebody, at the back of the classroom who's got a loaded weapon in his backpack or her backpack, and will shoot that person, and everybody between him and those two people are kind of caught in the crossfire. I don't know. It's just disturbing to me to think about that. But anyway, those are trends in America these days, and gun policy is certainly something that is going to be an issue in the public discourse for quite a while. Other nations have enacted very sensible gun laws, and while they're not free of all sorts of mass shootings, they sure have a lot less of them than we do. The text describes three different systems around the world, and I really want you to read about those systems because they show you other healthcare systems, socialized healthcare systems that are working in Canada, in Great Britain, and in Australia. And those are just some of them. I mean, there are ones all over Europe and many other parts around the globe. And so these systems work. Now they each have their defects and defaults, but one of the things the text points out to you is the residents of those countries really like their healthcare systems. They don't want the American system. Yes, they're one of the big things you hear from the AMA And many of our leaders, when they're worried about socialized medicine and big government and all that kind of thing, they talk about the long waiting lists and for services and things. We're talking about elective surgeries. We're not talking about needed surgeries. And sometimes there are longer waiting periods for elective surgeries. I think it was mentioned that 4 months in Canada, I think, or something like that for one particular service. Just as an example, I mean, I had a medical procedure here. It was not a life-threatening issue at all or anything like that, but I was referred by my physician for that procedure, I think, in May. And I met with a nurse to gather information about that in July. And the procedure actually happened in August. So that's like 4 months. And this is by somebody who's fully insured in America. And so we have waiting periods too. Everybody's got waiting periods. It's not a, it's, don't think for a minute that the minute you snap your fingers, you're going to get medical care in America any more than you would in Great Britain or Canada or Australia. These programs have universal entitlement with some options in a few of those nations for added private coverage if the person desires it to assist them in getting payment. I mean, some of them they have some payments to make. Others don't, I believe. But anyway, the thing is health coverage is available to everyone in those nations. The text points out that a medical approach that emphasizes disease treatment over primary care and preventive medicine, now that's us, usually results in good care, but for fewer people. Healthcare systems that emphasize personal and primary care, accessibility, and free or inexpensive services typically reach more people. So it is our values that really drive our system. And there are a number of those values. If you go back to week one in this course, we looked at American values. There's a number of those values that come into play in when trying to design this healthcare system. Should healthcare access be a right or should it be a privilege? That's the big question for us. There are options suggested in the text, and by the way, I said I encourage you to read up on those other nations. You're not going to have questions in the test about specifics of any of those countries, so don't worry about memorizing that or anything. But please do read about them because there's some really good information in those. And you're always going to hear about Canada. Oh, Canadians don't like their system. The Canadians I've talked to a person, all like their system, and all of them say they wouldn't want our system. So, everybody's got an anecdote, I guess, about somebody that ran into some bad thing, but in general, the system seemed to be working well. Now, some of the suggestions that are offered in the text as alternatives to what we have, the National Health Services as in the United Kingdom, Great Britain, and is comprehensive health care that is presented as a right of citizenship, free to all, and about the question about doctors, who's going to want to go to school if they're not going to be able to make money. Well, first of all, there's nothing to be said that doctors aren't living well in Great Britain and in other socialized medicine countries, because they are. And if they're going to make less money, the National Health Service in the UK provides some funding for medical education in exchange for periods of service in underutilized or underserved areas of the nation. So there's still an incentive for people to study medicine. And aside from that, if your physician is in medicine only because he make a lot of money, I don't think I'd want him doing the operation myself. National health insurance is another alternative to the health services. That's what Canada has, basically, a single payer insurance plan where states, in Canada at least, and likely here in the United States, the states have the responsibility for delivery of health services. That makes allowance for private medical practices but discontinues private health insurance. So private medical practice can still exist, but the whole notion of private health insurance is just set aside. There's no need for that. Now, there are apparently some health insurance companies that offer supplemental insurance, but the notion of big health insurance like we have here is not necessary in Canada. And there's all sorts of different iterations, that allow for insurance pools, fees for low income self insurers, those kinds of things. Another option is incremental health reform, proposing things such as tax sheltered medical savings accounts. Alaska's, at least Alaska and the university, both have these options where you can actually just dedicate part of your pay to be put in an account that before taxes, and I think it's even as you draw it out to pay for medical expenses, it's not taxable. Could be wrong about that, but at least that's one option. That's one proposal. Um, those kinds of things. And then the Affordable Care Act, which really is a part of incremental health reform, I think, was sort of our nation's nudging, our healthcare system towards a more nationalized system, implemented in 2010 under Barack Obama, what we call Obamacare. It's too bad that his name, Obamacare is the name, because that's one of the things that just drives a lot of people to be opposed to the ACA. And really, as you may know, the ACA was really fashioned after the health insurance system that the state of Massachusetts set up. I mean, very much so, very closely designed after that system, which was, I think, pretty successful in Massachusetts, implemented by a Republican governor who just happened to be Mitt Romney, and who ran against Obama in 2012. Interestingly, he didn't really make a big ballyhoo about how his health insurance system was working in Massachusetts, um, but the ACA extended insurance coverage to an additional 32 million people. Included such things as an individual mandate, so that everybody who was to be covered under the ACA had to have insurance. People object to that. Uh, if you drive a car, you have to have auto insurance. Nobody seems to object to that. Why do we have to object to having health insurance? Hopefully you're never going to have to use your auto insurance, and yet you pay for it, every 6 months or every month or however often. But if you need it, thank God you have it, right? And it's the same thing with health insurance. Young and healthy people in particular oftentimes think they don't need health insurance. It just takes one accident, and all of a sudden you need it. And and if you don't have it, who's going to pay for it is the rest of the population, because if you get treatment that you don't pay for, you can't pay for because you don't have insurance, you don't have any money. Yeah, the hospital will write it off eventually, but what's going to happen to the hospital fees for the rest of the population? It's all going to go up. And so everybody already is paying for uninsured people. And so the idea that, it's one of the complaints about the ACA. Why should I have to pay taxes for somebody that doesn't have their own insurance when I have mine? You're already paying for people that don't have their insurance. You just don't know it. Subsidies, so that the government can assist individuals that don't have as much money to pay some of the fees. Now, the problem with the ACA, certainly in Alaska and other states, is there's not enough competition, and that's because the private insurance companies are the ones that are doing the competing there. There's supposed to be a marketplace of different insurance companies, and the insurance companies are still pursuing profit, and if they don't find the providing the services profitable, they pull out of the market. And in Alaska, I think you're left with one provider, and that's the situation in several states. And I think in some counties, really, some counties in the United States, that nobody is even offering insurance. It's oddly so. This that profit motive that is really screwing up the ACA. It's not the design of the program; it's the fact that insurance companies are still chasing profits. So um, there were a lot of regulations put in place also to change the way insurance companies, um, operate, so that, for instance, they couldn't deny coverage for pre-existing conditions. Something they had to include children in their parents' coverage up to age 26, uh, uh, lifting the lifetime caps on coverage, those kinds of things. And for all of the resistance to the ACA that's out there, and the questions about the future of the Affordable Care Act, is really being actively undermined by the current administration. Um, the fact is that the ACA has been successful in changing the perceptions of Americans about whether or not they have a right to health coverage. More and more Americans now see health coverage, health insurance coverage, access to health care as a human right, not as something that they have to purchase because they can afford it. The things like the coverage for pre-existing conditions, the coverage of children up to age 26, those things have been very popular. And the people that are trying to do away with the ACA understand they can't take those things away anymore. Americans have them now, and they're demanding them. And I think that's a significant shift in thinking about health insurance. And so whether in the long run the Affordable Care Act is successful or not, that's one thing that the ACA has accomplished, I think, and has forever changed thinking in America. It's one of those paradigm shifts we talked about a little while ago. So the text, our authors say, one is hard pressed to understand the extreme Republican vitriol towards Obamacare, especially given the absence of an alternative proposal. In early 2016, the Republican Congress had voted more than 50 times. I think that's by early 2016. The Republican Congress had voted more than 50 times to repeal all or parts of the ACA. In none of those instances was an alternative to the ACA proposed. Uh, as I mentioned earlier, there were some suits brought by the states and different organizations to the Supreme Court. The big ruling in 2012 was long awaited for by the public, and the Supreme Court upheld almost all of the Affordable Care Act with the exception of the requirement that the states all expand Medicaid coverage. The court didn't think that the federal government could require that, and that's where a lot of the states pulled out of the Medicaid expansion. Um, but it did upheld in 2015, I think, the ruling, uh, the requirement that health insurance subsidies, or rather the allowance for health insurance subsidies for qualifying Americans, the um, um, states have been, I think, trying to undermine the ACA by saying that that was an unconstitutional thing, but the court said that it was constitutional for the federal government to do that. Compared to and as I mentioned here, there's all sorts of efforts by this current administration to undermine the effectiveness of the system through a lot of different administrative actions. Just pay attention to the news and you'll see them. And still, no good proposal to replace it. I think Republican Congress at one time had some sort of health insurance plan proposed, but there were all sorts of issues with it that really made it unworkable. Compared to industrialized nations with less costly healthcare systems, Americans do not have a greater longevity. In many cases, we have a shorter life expectancy than other advanced nations. Most cases, perhaps. We have higher rates of infant mortality than any other industrialized nation in the world, even though it's improved over what it was before Medicaid was implemented. And we are one of the few nations where medical expenses can cause poverty. We're also, I think, the only nation in the world that doesn't offer a maternity leave, a paid maternity leave, also. Although that's something interestingly that has been proposed recently. Our advocacy, the text says, ought to focus on certain principles, and these included principles of universality of coverage, um, taking healthcare out of the marketplace. Somebody mentioned to me recently when I made a post somewhere about in Facebook about healthcare. Oh, healthcare is always going to be, going to be a commodity in the market, and I said it doesn't have to be at all by any means. It doesn't have to be in the market at all. Curbing the rise in drug costs is another cause that needs serious advocacy. Ensuring the equity of coverage for persons of all incomes, greater access to primary care and prevention, not just specialists, but to actually have individuals who can take care of you before you're really deathly sick, and reducing administrative costs, which is a big thing for saving money in our system. We pay more for our healthcare system than any other nation in the world, and our results are just not up to speed with the rest of the world. Accessible healthcare, according to our authors, should be a universal right for all U.S. citizens, not a privilege to be purchased or earned through workplace participation. And I agree with that. So, if you haven't seen this film, Michael Moore produced the film. Now it's probably 15 years old, perhaps, called Sicko. And if you haven't seen it, I really recommend you take a look at this. This looks at the American healthcare system for insured Americans. Now, these are people with private insurance, and compares them to the healthcare systems in Canada, Great Britain, France, and Cuba. I think it's just four other nations. Really eye-opening and really worth watching. You know, a lot of people don't like Michael Moore. He has a real abrasive kind of way about him, but as I tell my students in the Introduction to Social Welfare, he's sort of the Upton Sinclair of the 21st century. You know, he's a muckraker, just like the muckrakers were 100 years ago in our society. He's really pointing out the defects in our society and asking us to take a look at what we need to do to change them. So this is a great movie, and I really do recommend it to you if you haven't seen it already. All right, that's it. And if you have any thoughts about this content, I'll be interested in hearing them. So let me know. Thanks.